Good job.
Hi, everybody. We're just going to give 1 more minute to allow people space to jump in before we'll start with today's session. In the meantime, can everybody just give it a little introduction of themselves in the chat, all of the attendees? Just tell me who you are and where you're watching us from so that we can grow our REFA community. And hopefully that'll also give me an indication that people can hear me and see me. Aha, hello, Susan.
Hello, Susan.
Hello. Okay, people are rolling in and it's 2 past. So let's start with the formalities and the introductions so that by the time everybody's settled in and has given their introductions in the chat, we'll be ready to start with the discussion quite promptly. So hi, everybody. While we're waiting just to start, don't forget to put your introductions in the chat, but I'll begin. So my name is Shannon Wardlaw, and I'll be the facilitator of today's discussion. I'm also the vice chairperson of REFA at Wits University here in South Africa, and I'm a postgraduate student in institutional studies. So as the facilitator today, I'm going to be moderating the conversation. However, there are some points of ground rules that if we can all adhere to, it's just going to make my job a lot easier. So firstly, this is specifically for the attendees. The chat is a great place for commentary and dropping any relevant links to research that contributes to the conversation. However, please maintain professionalism in the chat. And if you could, please filter your questions into the Q&A section, which you should be able to find under the video. It's just marked as Q&A and it's got 2 little bubbles. If you don't see it, hover your mouse around that area and it should pop up. Secondly, then for speakers, and to also explain the structure for the attendees, presentations are going to be limited to 15 minutes to make space for audience engagement. So again, we really encourage the audience to ask questions, even questions of clarity, or asking for more discussion on certain points that the speakers have brought up on topics so that we know what direction of the conversation to continue. And that again goes into the Q&A section, but also just to explain that I'm going to be quite rude and give the speakers a constant indication of how much time they are using so that you guys understand. So introducing the topic of today that we're going to be speaking on, it's called The Role of Global Inequality in the COVID-19 Crisis. And this is part of stream 4 of the REFA Festival, the impact of the crisis on African economies. Why this is specifically an important conversation to have is because different countries have vastly different experiences of the economic shock, and they're different in their abilities and their approaches to dealing with this shock. So this conversation specifically explores the heterogeneity between the global south and global north, as well as across emerging economies. And we're going to have a particular focus on African economies. Specifically in this session, we'll focus on the global south versus global north's dynamics and how they have impacted the pandemic and how it has played out. This is also, again, still going to focus on African economies, but you can assume the dichotomy against the global north unless stated otherwise throughout the conversation. I think also over the course of this panel, we're going to have very different perspectives about the role that inequality has played. But the purpose of this multidisciplinary panel is so that we can all leave this chat with a holistic view of the intersections between health, poverty, and the economy. Now to just introduce the speakers who are going to be contributing to today's chat. Our first speaker is going to be Vuyokazi Futshane. Vuyokazi is a Pan-Africanist, a feminist, a global development activist, and a futurist with a focus on the eradication of poverty economic and tax justice, and applying an intersectional gender lens to developmental issues. She is currently a project officer at Oxfam South Africa and is completing a master's in analyzing the lived experiences of sex workers. Previously, Vuyo has worked on issues of tax justice at the G20 level and the SADC's Basic Income Grant campaign. Vuyo is also a prominent contributor to the youth discourse on social, political, and economic issues in South Africa, and is committed to women's, queer, and gender diverse people's struggles, specifically in the creation of a gender-inclusive national budget and policy-making approaches. In other words, Vuyo and I should be best friends after this, and we thank Vuyo so much for being here today. Our second speaker who's going to be contributing today is Maureen Mackintosh. Maureen is a professor of economics at Open University and a development economist specializing in the economics of markets for healthcare and medicine, specifically African health systems. Maureen is also the principal investigator on a collaborative research project with Tanzanian, Kenyan, Indian, and UK colleagues titled GCRF Inclusive Societies, How to Link Industrial and Social Innovation for Inclusive Development, Lessons from Tackling Cancer Care in Africa, which was funded specifically by the UK ESRC. Maureen is also a co-author on the commercialization of healthcare, global and local dynamics and policy responses, published in 2005, and has published, Vuyo, we can hear you, and has published Lessons from COVID-19, 2021, and Local Manufacturing for Health in Africa in the Time of COVID-19, Experiences and Lessons for Policy, also in 2021. Both of these also had co-authors, and this is what Maureen is going to be speaking on today. Our last speaker for today's event is going to be Chijioke Nwosu. He is a development economist. Specifically, his research interests are in the areas of health and labor market outcomes, healthcare financing in developing countries, and the relationship between gender and poverty, and food and nutrition security dynamics in developing countries. So basically everything. Through this, he's also worked on various projects with public and non-governmental clients, published several peer-reviewed articles, and presented papers internationally. He's currently a senior research specialist at the Impact Center at the HSRC, and is postdoctoral fellowships at both the HSRC and the Georgia State University in Atlanta. He obtained his PhD in economics from the University of Cape Town, and as a postgraduate student, he also won several academic grants and scholarships, including the Swedish International Development Cooperative Agencies. I've lost my place. Graduate Scholarship, the Carnegie Fellowship for Doctoral Study, and the African Research Consortium Doctoral Thesis Grant. So welcome to that speaker as well. Without any further ado, I think we've got quite a few attendees here to be able to start the conversation. So I'd like to introduce our first speaker, Vuyo, to give us their presentation and their contributions to the chat. Thank you so much. And here is Vuyo.
Thanks so much, Shannon. And sorry, guys, I think I'm going to be coughing throughout this whole thing because I'm still a little bit sick with the flu, but I'm going to try and get through it as seamlessly as possible. So I have the honor of being the first speaker of the session, and I was asked to draw on a paper that I recently presented at a UN meeting on recovering from COVID and inequality in South Africa specifically. Plus, at Oxfam South Africa, we have done quite a lot of work on inequality. So this is an area when it comes to speaking about global inequality and the COVID crisis. It's something at our organization that we work on quite a bit as our focus. So I think to begin with, I think everyone is familiar with the saying or the fact that South Africa is known as one of the most and arguably the most unequal society in the world. And this is something combined with extreme levels of poverty and unemployment. And South Africa now has one of the highest unemployment rates in the world, has created an unequitable society that has been passed on from one generation to the next generation. And with the COVID-19 pandemic, that has been exacerbated. So a few months ago, when I presented the paper on recovering from COVID-19 and inequality in South Africa, which I will be drawing my inputs from largely today, so I will just highlight some of the key things that were outlined in that paper, which I think I can share the link in the chat at the end of my presentation for people to go through it further if they are interested. So, so to begin with, I highlighted that one of the issues that pertains to inequality in South Africa is to take a historical step back, because it's important to trace the root causes of poverty and inequality in South Africa, so as to understand more holistically how these problems have come about, how they continue to be reproduced, and also trace the intergenerational consequences of poverty and inequality in South Africa. As many of us in South Africa know, historically, these were designed and engineered through the apartheid and colonization system, through public policy and laws that fundamentally structured an unequal society that we inherited even post the democratic transition. And these laws and policies benefited mostly the white minority and dispossessed the Black majority, which is why 27 years on, we can still see when it comes to poverty and inequality that the people who are affected most adversely are people of color and Black people in South Africa. So even though the laws were abolished, the country has massive disparity in terms of wealth distribution, unequal access to public services, and political power. And the pandemic has only reinforced the severity of these inequalities that have persisted from generation to generation. So currently, South Africa's Gini coefficient is one of the highest in the world at, I think it's 0.63, according to the latest estimates by the World Bank. And in simple terms, that means that the majority of the population, who are predominantly Black people, are not benefiting or participating in economic activities as much as the minority. So to illustrate some of the intersectional aspects of inequality in South Africa, at Oxfam South Africa, we published a report focusing on inequality in South Africa, focusing specifically on women, work, and income. And in the report, it was found that it would take the pay of 461 Black women from the bottom 10% of earners to make as much as one white average male CEO takes in a year. It also takes just 23 hours for the average CEO to earn what the average worker earns in a year. And moreover, the World Bank estimates that the richest 20% of people in South Africa control almost 70% of our resources. So that is just a few figures that kind of depict how the dynamics of inequality in South Africa are both racialized, are both gendered, and also have class dimensions. And even in, when we look at the job market where we do find people who are employed, there's still also a racial and gendered bias as well. For example, on average, a woman earns 30% less than a man in the job market, and men are more likely to find employment. And even now, most recently, in the Quarter Force Labor Lease survey, it was found that on average, across all racial groups, white South Africans are the highest income earners across all sectors. And also, this is also further exacerbated by the fact that when it comes to Black female-headed households in South Africa, they are the most impoverished and they have more dependents to support than male-headed or male and female-headed households. I'm not sure how I'm doing on time, but essentially, the aim to eradicate inequality in South Africa has not only stagnated, but it has actually accelerated in the sense that it's become more pronounced. It's multidimensional, it's intergenerational, and it's intersectional as well. And zooming in on the pandemic, as mentioned before, that with the pandemic, the inequalities that we've been experiencing and the accompanying challenges of inequality in South Africa, those have only been worsened and magnified because of the pandemic, right? So South Africa now is one of the most badly affected countries in the world in terms of COVID-19 statistics. And also, I think it's the most affected on the continent specifically. And the issue now has been that, for instance, many households who rely on the informal labor market, a lot of those households have been affected in the sense that their main breadwinners have not been able to earn incomes. And I think, according to Stats SA, it was shown that I think 2 out of every 3 workers has been unable to find work during this pandemic. And I think that's why also we've seen such an increase in the unemployment numbers that we are now faced with. How am I still doing with time? Okay, I think I'm still fine. So with the recent publication of the quarterly labor force survey, again, it was found that the labor market is more favorable to men, more general than it is women. Men are more likely to be in paid employment regardless of their race, while women are more likely to be doing unpaid work, which is another thing that I think the pandemic has shown. It's that now we've come to also realize the issue of time poverty, where women have less time to devote to domestic and unpaid care work, because now with people being locked down, there's the additional burden of having to do more of that labor, which has sort of reduced the time that women have to participate in economic activities. And women generally bear the brunt of unpaid labor more than men do. And I think beyond the unemployment crisis, the COVID-19 pandemic is a virus of inequality. And as I said, it's had an effect of continuing inequality. I think it was this year Oxfam International published a report, and it was actually found that 4 of South Africa's billionaires have seen their fortunes actually increase during the pandemic, while it will take over a decade for the world's poorest to recover from this current pandemic. And their wealth has increased so much so that they would be able to give every one of the 59 million poorest South Africans a check of over 14,000 Rand each. And that just shows the inequalities and the imbalances that while the pandemic for the working class and the poor has had a devastating effect, it has actually worked in the favors of billionaires who have been able to multiply their wealth and were able to even accumulate more wealth and resources during this time, which is, mind-blowing if you think about how many people have actually been dispossessed by this pandemic. And also in South Africa, we are now currently experiencing one of the worst or the highest rates of food inflation that we have experienced, I think, in the last 4 years. The current rate of food inflation now is even worse than the times we've been experiencing severe droughts. So yeah, and also there's also the issue of the spatial planning and how people in informal and peri-urban areas have experienced this pandemic the worst, because those areas are areas where there are less resources in terms of water and sanitation, service delivery, and poor infrastructure, and those have only been worsened. So in sort of wrapping up and thinking about some of the recommendations to to address these problems, the COVID-19 pandemic has greatly affected economies across the globe. And undoubtedly, as we've seen, South Africa's economy has been worsened or affected quite badly by the pandemic. And our economy was already in a state of, vulnerability. Many have lost their jobs, many businesses have shut down, and many will continue to do so. Increasing inflation, poverty, and inequality is expected to deepen over the next couple of years, even post the pandemic. So I think in order to breathe life into a post-pandemic economy, our health interventions also need to be coupled with progressive economic recovery plans. So I think in many parts of the world, the issue of widening social protection is something that's been tabled, and it's something that has been experimented with and has been found to actually work in terms of, redressing or addressing some of the issues that we're faced with. So that is also a recommendation that I would make in terms of what South Africa would need to do in terms of addressing the issues that have been brought forward or have been magnified by this pandemic. So I think, widening social protection by rolling out a universal basic income grant. I think many organizations, even within the IEJ, have written extensively about the issue of rolling out a universal basic income grant and its benefits. So I think, that's one of the key recommendations. And also the inclusion of Black women and the youth in the economic inclusion of Black women and the youth. As previously mentioned, South Africa's unemployment crisis is out of control, and those who are most affected by it are Black women and the youth. Okay, 5 minutes left. And also with the burden of unpaid care work. So South Africa needs, to mainstream gendered industrial and economic policies that will ensure equity, through incentivizing industries in bridging the gender gap in both labor force participation and reducing the gender wage gap. I see I have a few minutes left. And also redistributive and equitable tax measures. And that is the institution of a wealth tax, increasing protection for informal and precarious workers. As mentioned before, informal workers have had one of the most difficult times during this pandemic in terms of participating in the economy. And also there's no protection for informal workers, there's no safety nets. And I think with the high levels of unemployment in this country, the informal sector is a sector that we can actually leverage on in terms of increasing economic participation and, boosting the contribution that that sector could potentially have to our GDP. I think I'll leave it there before I run out of breath. But that is my presentation in a nutshell.
Sure. Thank you so much for that presentation, Vuyo, because that already touched on, firstly, the core of what we want to come out of this session. I think you've created like a perfect idea of the context of the situation. I know we spoke largely about South Africa, but this is obviously going to apply to a lot of countries in the global South, but also just the core question or the core thing we want to discuss in today's session, which is talking about when we have this pandemic, when we have this virus, it's not a blanket effect. The inequalities that we've previously experienced, and you noted gender, race, history, intergenerational, spatial access to opportunity inequalities, all have contributed to the landscape, to our ability to respond to the pandemic. So we shouldn't leave those intersections out of our responses, out of the way that we critique our pandemic responses and look at it. And I mean, there was a lot that you brought in there today. So I think we'll talk about more of that at the end of the session, because I'd now like to bring Maureen into this conversation. And let's see what you want to contribute further to how we're going to look at pandemic responses.
Thank very much indeed. Can people see the presentation slides?
We can see the slides, but not you.
Okay, is that? I think that's probably okay, but I'll see how my video link works, because sometimes with it on it wobbles. So let's see how I go. Okay, so this is a presentation which is called Medical Manufacturing and Inequality. So it's looking particularly at manufacturing for healthcare through the COVID-19 crisis and the implications for industrialization, inclusion, and rethinking economics. So it's a presentation which has been written by 4 of us, including, you can see at the bottom, Jeffrey Banda, Julius Magwagwa, and Andrew Mkwashi, and all 3 of them are participating. So I'd better get this right, and no doubt they'll leap in and say their own comments. I may say also that this is based on work that we're doing for the IEJ. It was commissioned by Bandili, so I'm hoping he's going to like it. It's very much interim work, Bandili. So let me see if this will turn over at the moment. There we go. So start with the issue of COVID-19, just keeping on time. So starting with the issue of COVID-19 and inequality, and very much picking up from what Vuyo was saying. I mean, the pandemic's generated an exacerbation. It's made an international and local inequality worse. And there are a number of ways, in terms of my concerns here for medical manufacturing, how that's happened. I mean, as is well known, the pandemic's generated a collapse in supply chains across sub-Saharan Africa, very much not just in, I'm just trying to make sure I can see this and also see myself talking. Here we go. Not just in South Africa itself. It's made international inequality in health much worse, notably as high-income countries have monopolized international procurement and vaccine development and deployment. Sub-Saharan African countries started off the pandemic, as we know, with a weak medical manufacturing base. By medical manufacturing, I mean pharmaceuticals, medical devices, laboratory chemicals, all of those things that are needed, including all the practical commodities. And import dependence and low purchasing power has meant huge problems for health systems coping with COVID-19. There are, however, some countries which had a somewhat less weak, somewhat less stronger medical manufacturing base in 2020 going into this. And they have also remarkably been able to innovate and to respond to the crisis, so that we've seen across African countries production of sanitizer, protective equipment, test kits, oxygen delivery, ventilators, a remarkable range, actually, of innovations using local available inputs. And one African manufacturer who was talking in a webinar that we ran back in about October 2020 said, you know, some of these innovations were by people who simply weren't given the opportunity to innovate in a pre-COVID world. So COVID-19 has both demonstrated to everybody how important local manufacturing is, and for medical emergencies, for health security, for healthcare, and at the same time has identified some opportunities. And as I said, this follows on, this is part of work that the 4 of us are doing for the IEJ. So one of the things we've done is we've done I'm going to have to move this, let me see if that works, yes. One of the things we've done is we've done a survey of medical manufacturing across Africa. And the first thing that stands out from that is the dominance of North Africa. North Africa is way ahead of sub-Saharan Africa in medical manufacturing. It's producing basic and more complex generic drugs. It's producing some originator drugs, a range of sterile production of goods such as injectables. It's supplying, local production is supplying a very substantial part of their domestic markets. And COVID-19 has seen a rise in North Africa in a big number of international collaborations and buyouts that are pushing the technology in North African medical manufacturing upmarket. Firms like Biopharm in Algeria, Amun and Sedico in Biotech in Egypt, Mafar and Sosema, which is a Russian joint venture in Morocco, are really raising the capabilities of North African medical manufacturing. In vaccines, which is obviously an important issue right now, there's a long history of work in North Africa with the Institut Pasteur, in Morocco, Algeria, and Tunisia, and in Egypt by Vaxera, which is the oldest vaccine manufacturing in Africa as a whole and in the Middle East, which has benefited over many years from government support. And this year has started manufacturing the Sinovac vaccine. It's the first vaccine being manufactured in the subcontinent, in the continent of Africa. And these firms are major exporters to Europe and the Middle East. There's a real contrast with medical manufacturing in sub-Saharan Africa. This is a little bit of history. The main sub-Saharan African medical manufacturing hubs are Kenya, South Africa, which is the largest, Nigeria, Ethiopia, Ghana, and some others, including Zimbabwe, which has deteriorated, Tanzania, which has struggled a bit, Uganda, which has been increasing. This industrial history goes, in pharmaceuticals, for example, goes right back to the 1930s. These are not new industries. In South Africa, Zimbabwe, Nigeria, Kenya. The 1960s and the 1970s saw lots of government support for expansion in medical manufacturing, for example, in Tanzania, in Ghana, newly independent countries. And then the 1980s crisis, right across sub-Saharan Africa, and the economic crisis, saw most multinational companies operating in the subcontinent leaving the market to local family-owned businesses. In recent years, before the pandemic, there have been an increasing number of joint ventures with our Indian multinationals, and we've seen the emergence of Aspen, which is a large South Africa-based multinational. So if you're looking at the trade comparisons, what you can see, this is just a few countries which are hubs. Egypt and South Africa, big manufacturers, are also very large importers. These are richer countries, and in both countries, the benefits of those imports are unequally distributed. In sub-Saharan Africa, only South Africa and Kenya have really measurable quantities of exports, and imports dominate the requirements of the health sector in really all sub-Saharan African countries, including South Africa. So medical manufacturing, which is an important industry, as shown up by COVID, what are its strengths and weaknesses, and what's going on across these, specifically sub-Saharan Africa? First of all, we know that local manufacturing is an important source of low-cost medicines for the population right across the subcontinent. And that's very notably the case in rural areas. There's a huge gap between need and access to medicines and medical devices right across sub-Saharan Africa. And it's exacerbated by exclusionary prices and widespread charging, and has been made worse by COVID-19. There are some local manufacturing strengths. Those are in basic generics, including tablets, capsules, syrups, creams, antibiotics, including beta-lactams, which is the penicillins, some of which production has been collapsing against import competition, some of it dumping. And there are ranges that are now expanding into non-communicable disease drugs, and notably for diabetes and hypertension. There are some injectables production, not nearly enough, notably in Kenya, where it's struggling, and in South Africa, where there is a substantial capability. There are some specialist activities. For example, Ethiopia is exporting hard capsule shells right across the sub-Saharan Africa, particularly Eastern and Southern, and that's a joint venture with a Chinese firm. There's relatively little in-licensing of innovator drugs. South Africa is really the main place, not very much of it there. And the medical device sector is frankly a disaster. It's neglected right across sub-Saharan Africa. There's very little regulatory support or incentives, and really only South Africa has a small emerging sector. Kenya has one good producer, which is an exporter, but that's all. And even excipients manufacture, which is an opportunity. This is things like starch, which is largely agricultural in origin. It's all still imported. So if you then look at vaccines and biotech, which is right in the news now, and I owe this slide to Jeffrey Banda, who will comment on it himself if anyone wants information. Vaccines manufacturing capability is virtually absent in sub-Saharan Africa. It's just Senegal, which has a long history of being one of the main producers of yellow fever vaccines in the Institut Pasteur, and South Africa, which has Biovac, which is still really still developing, not yet producing its own vaccines. COVID-19's changed the landscape for vaccines and biotech. Biovac in South Africa is now working with Sanofi and Pfizer. They're only at the moment in the fill and finish for existing vaccines. Aspen is developing a preliminary agreement with Johnson & Johnson for their COVID-19 vaccine, not started yet. And there are other countries which are at preliminary stages of international collaboration on the slide there. The point I think we want to make is that biotech platforms are an opportunity. This is a platform which includes vaccines, but is much wider than vaccines, which is an opportunity for African countries to use the vaccine opportunity to develop this scientific and manufacturing capability, because donors and countries are registering the importance of local manufacturing, and maybe big pharma seeing local licensing and joint ventures as an alternative to conceding patent rights, which provides a technology transfer opportunity, which can be leveraged. So that we're seeing the African CDC picking this up. We're seeing that biotech has been, although it's been long neglected in South Africa, there are postgraduate programs which could feed it. And this is really an opportunity for technology leapfrogging. It's important. And ask questions of Jeff if you want to know more. He's online. So thoughts about industrial policy design and the role of industrial economics, given that this is a Rethinking Economics workshop. What's happening, I think, is that industrialization has returned to priority for many African governments, and that's been hugely reinforced by the pandemic urgency, as my colleague Julius Magwagwa has pointed out in many forums recently. The industry policy, however, in Sub-Saharan Africa really has yet to develop strong capabilities in sectoral support of the kind which have existed for decades, for example, in East Asia. What I mean by that is the capability in industrial policy to promote clustering of competing firms using related skills and proximity, to promote industrial deepening, where is the production of excipients, better packaging, supporting skills development, regulating employment status so that these skills really develop and these develop into good jobs for locals across sub-Saharan African countries, generating sources of patient capital for industrial development, hugely lacking across Africa, identifying and supporting appropriate business models, making sure that these skills are retained, identifying industrial protection needs for emerging clusters, supporting African firms, responding to dumping, strengthening regulation, including well-designed content, local content rules. A number of countries have local content rules, they're not really being properly used, supporting international linkages to make sure that technology transfer really happens onto the continent. All this requires a move in economic terms away from these so-called level playing field approaches, everybody should have the same opportunities, to a sectoral focus on building industrial sectors in African countries. And for medical manufacturing, that means recognizing that health sector procurement is an industrial policy tool. It supports both access to care and industrial employment. And in terms of economics, what that means is strengthening industrial economics in Africa, in health, in higher education, and in policymaking. Extraordinarily, really, economics training in higher education in sub-Saharan African countries has really neglected industrial economics over decades. As somebody mentioned yesterday in the plenary, the collaborative master's program in economics from the AERC still doesn't offer industrial economics as a specialism, despite the policy emphases in African countries. So I'm suggesting that an important element of rethinking economics for Africa really is to focus on industrial economics. And the reason for this are, I think, threefold. One is that the core industrial economics discipline is distinctive within economics. First of all, it's strongly historically focused. Secondly, it's used case study techniques right from the start. And third, it's been the pioneer in terms of evolutionary economic modeling that takes history into account.
Maureen,
it's a discipline. How many?
3 minutes left.
That's fine. Next one is the conclusion. The discipline can address innovation, which is the driver of productivity and competition, much more effectively than standard neoclassical market analysis. It's a very important input to modern competition policy in high-income countries, but not yet in Africa, since it can address demonopolization, which is crucial for tackling inequality, something our previous speaker really mentioned when talking about the few very high-income people. And it's an essential underpinning for innovation-focused industrial policy. It brings in heterodox developmental economics approaches into general economics teaching, helping to update it, support developmental economics perspectives, and it's much more appropriate for developing local solutions. So what's our conclusion? The conclusion is that it's important to try to build a health and industrial complex, that's Brazilian language, in fact, to address inequality and health security in African countries. It's a medium-term objective. What will it take? It takes, this is one of Julius McGuirk's favorite phrases in writing this, it takes leveraging local knowledge and understanding, first of all, focusing on building on local assets and capabilities, not on what's missing, but what you have to start with, and learning from the COVID-19 experience, not losing it. It involves generating critical cross-sectoral collaborations and linkages among manufacturing, health, finance, tertiary education, which means in turn tackling the economics of industry, of innovation, and of healthcare together, not in separate silos. It means recognizing that public procurement and regulation are core elements of developmental thinking in the area of medical manufacturing. It involves improving and using foresight, looking at what sort of the emerging health challenges and the manufacturing implications. And maybe finally, and perhaps the single most important issue, it involves bringing political economy much more centrally into economics by including issues of power, agency, and resource allocation in policy framing in order to strengthen local economies and health systems. And that's our conclusion. And thank you very much for listening.
Thank you very much, Maureen. Let me just also put my video on so you can see my face. Thank you very much for that. I think that also is a great building block onto the idea that things cannot stay the same, because we're now looking at pluralist approaches about developing the state to create a more inclusive and secure form of economic opportunity. And I think this research that you've done really takes like a bold stance to the things need to completely change. We need to look at a complete different direction of doing things. And I think that that's a fantastic contribution that people can then mull over and see if they want to have any sort of debate in. Speaking on that point, remember people, the Q&A function is there. It is calling your name, put your questions in there so that we can make sure you understand everything and that your perspectives are also taken into account at the end of the session. The next speaker I'd like to call in for today's discussion is Chijioke. They're also going to be contributing in terms of the health sector and economics. So whenever you're ready to share your screen, then we'll continue with the presentation.
Thank you very much. Okay. So thank you very much, Shannon. And are you all seeing the presentation?
Yes, I am.
Let me see something here. For some reason, my screen just froze. Let me just see. Is Shannon still sharing?
It is sharing, and we can see things moving. There, we can see the slides now.
Okay, I see my presentation now, my slides. I see my slides?
Yes, can see it.
Okay, awesome. Thank you very much. So my name is Chijioke, as I've been introduced before, and I'm presenting on healthcare financing in developing countries, looking at COVID and inequality. And frankly, the presentation is going to also touch on just general issues of health, not just healthcare financing, but towards the end, I will zero in on financing, just to see where we are as a people, where we were before the pandemic, and also where we are, going forward. And by way of introduction, we know that unfortunately Africa, contributes a lot to the global disease burden. And we can see from this graph, because you'll be seeing a lot of graphs today, but basically, because I like showing the pictures. Because they sort of stay more in people's minds. And we can see the lower graph, the blue line here, which is life expectancy at birth for Sub-Saharan Africa, which has been increasing, but still significantly lags behind the global average and the OECD average. And basically, this is why do we care about health? Of course, it's a no-brainer that health is intrinsically valuable. Perhaps the most important resource that we have as human beings. But also from the economics aspect, health is wealth. We have seen just from Maureen's presentation how important building a very sustainable industrial policy, especially with regard to medicine manufacture or pharmaceutical manufacture, can really be can play positive roles in economic development. And recently, the IMF just showed that faster progress in ending the current COVID crisis could add about $9 trillion to global GDP by 2025. So health is very important. And we know that COVID-19 has devastated the global economy. A lot of infections running in the hundreds of millions, more than 4 million deaths. And even though Africa is relatively spared in terms of recorded deaths and infections, but the continent has not been spared, especially also when you think about the economic implications. And so just also, though I will be focusing more on Sub-Saharan Africa, but I'm in South Africa. So, just looking at some of the impacts of the pandemic on health, going even similar to what Vuyo mentioned about women and about the inequalities, women being more adversely affected. We know that women, were more likely to lose their jobs in South Africa, for instance, during COVID-19, and even the poor. One research at the beginning of the pandemic, of the lockdown, estimated that the lowest earning income group in the labor market were about 7 times likely to lose their jobs, as the highest earning group. So we know that COVID has really created a lot of inequalities. And also, of course, the educational inequalities due to COVID, where learners are losing, poor learners are more likely to lose learning time. And also women, just reinforcing the earlier point. And of course, women, one of the mechanisms through which they are being adversely affected is that they are more likely to be working in sectors that were affected adversely by the pandemic. So basically, the pandemic has brought to fore systematic disparities in health and access to quality healthcare. And this is also true within rich countries where the poor and people of color are more likely to be affected. And even the problem is, I will argue, magnified in poor countries. A study that a colleague of mine and that we did recently just showed that even in South Africa, income-related health inequality, the level 5, level 4 lockdown period was about 6 times the pre-pandemic value. Pre-pandemic levels. So this is really remarkable. And funny enough, even as the economy starts recovering, these inequalities have become stubborn, because even when we re-estimated with more recent data, it's still about the same. So in terms of vaccinations, inequalities are glaring. So you can think about full vaccination. Canada is currently about 67%, Spain about 69%, the USA about 53% of the population fully vaccinated. But if you go to Africa CDC, you see only about 2.5% of Africa is fully vaccinated. and about 4.5% have only received one dose of the vaccine. And so you hear about booster jabs in in rich countries, whereas this is also in the same context of widespread non-vaccination in low-income countries. So, and of course, some of these outcomes are, as a result of the reinforcing nature of some practices that have inequality embedded in them, things like vaccine hoarding. And though we also admit that there are capacity constraints that have militated against low-income countries fully vaccinating their citizens. So basically, this is just painting a picture of glaring inequality. But how did we even get here? Because I mean, COVID-19 struck, but the problem is that COVID-19 has only magnified problems that have been existing. I mean, Maureen made a very brilliant presentation now about the pharmaceutical manufacture, indigenous pharmaceutical manufacture deficit that has been plaguing the continent or the region even before COVID times, and this has been magnified by the pandemic. And what I'm going to be showing in the following slides is just to show us why we are where we are in terms of the grossly inadequate amount of resources that African countries have been devoting to health. So this is health expenditure as a proportion of GDP. And you can see the top graph there is the OECD average. So as of 2018, it was more than 12% of GDP. But if you come to Sub-Saharan Africa at the lowest, you are seeing, that is just less than 6%, about 5%. So you also look at health expenditure per capita. This is just international dollars, basically. And you can see that even though Sub-Saharan Africa, the blue line below, has almost like doubled the per capita, the health expenditure per capita between 2000 and 2018, it's still abysmally low compared to whether you're looking at the world average, whether you're looking at the OECD average. South Africa here is almost trailing the world average, but as you can see from that Sub-Saharan African average, you can see a lot of disparities in the region. So when we talk about another metric, you look at domestic gross government health expenditure, so which is as a proportion of GDP, how much does the government spend? Because government is usually that player in the financing mix that tries to get to the poorest of the poor, that tries to correct some of the market failures that private involvement in health can cause. So you see that unfortunately, while there's a recommendation that government spend about 5% of GDP on health, you can see that the Sub-Saharan African average is just about 2% by 2018. And I mean, you can see the red line there is the 5%, which is a recommendation. You can see the world average, which is the gray line here. And you can see the OECD average, and this is South Africa here, but then this is Sub-Saharan Africa. So you can see whatever in index of health financing that you look, the region is lagging significantly behind, and there is not much hope going by current trends of a correction anytime soon. So another health, you look at it, I mean, these are talking about almost the same thing, and you look at the red. So the first graph here, the first bar chart here is just the government health expenditure as a proportion of current health expenditure at 31%. This is from the WHO 2000 to 2018 average. And you look at the second bar, which is the out-of-pocket spending as a proportion of current health expenditure, about 40%, which shouldn't be, this, because what this entails is that people are paying out of pocket a lot to access healthcare. And this leads to what is called, it can lead to catastrophe, which means that people are devoting too much of their resources to health, which can easily lead to impoverishment, which can, lead those households, those individuals into poverty. And if you look at the red bar, it's the government's health expenditure as a proportion of the government budget. It's 7%, whereas the Abuja declaration, said that countries should spend up to 15%. Government should spend up to 15% of their budget on health. But you can see the average is 7%. And in 7%, you can even imagine the heterogeneity in this within the region. There are some countries that maybe spending less than 5% or about 5%. The government spends out of their budget. So this points to gross negligence of the health sector. And of course, we have to even recognize that even this 15%, while the OECD average is about 18% of their budget, of course, we know that African governments' budgets are really very low. So we're even looking at, we are still underspending relative to that low budget. So this is really worrying.
About 3 minutes left.
Oh, I still have a lot to. Yeah. So anyway, so just quickly, one big figure that comes up here is that the health financing gap due to the pandemic has been estimated to be $66 billion per annum for Africa, and this is really frightening. That this is the health financing gap that we have, and it's about, if you look at if you expand the basket of countries in the developing world, you see about $270 billion that we need to be provided to plug this health gap on the continent. But in terms of the response to the pandemic, that's huge inequality. Recently, the IMF distributed SDRs, the special drawing rights, which is sort of a reserve currency by the IMF to help countries cushion the effect of COVID-19. And you can see that it's also the poor countries who need the resources more. Out of about $650 billion, only 21 billion was given to low-income countries, whereas the rich countries that are already more stable got the lion's share. And this is just how it was shared. I mean, you can see the US receiving a huge chunk of that. So there is, scandalous inequality in health resources on the continent. And what is the effect of all this COVID-19, these inequalities on African health systems? You can see HIV testing falling, TB referrals falling, and a whole lot of adverse health system issues there. And I won't speak to this because Maureen has given it adequate treatment, but some of the challenges we face as a region, we don't manufacture our own medicines. Maureen has given a very lovely presentation on this. And also we have human resource and infrastructure gaps on the continent. We have crippling debt where countries are spending up to 20% of tax revenue to service debts. In some countries, it's more than 30%. And public debt of Sub-Saharan Africa has jumped during the pandemic as a result of the pandemic by 6 percentage points. And another problem that African health systems are facing is that there's also a big dependence on foreign, on official development assistance, whereas the rich countries are cutting back. We saw recently that the UK cut back on its funding on ODA. Countries like Rwanda are exposed in terms of their health system. Health sector is being funded up to 47% from external sources. So these are the challenges that we have as a continent. But the opportunities that this presents to us, Maureen mentioned that this can actually be an opportunity for technological leap. So we need to manufacture our own pharmaceuticals. And the AFDB is talking about African Development Bank. It's talking about committing about $3 billion to indigenous pharmaceutical development.
Time to wrap up.
yeah, so I'm about wrapping up. And how can we get here? And a lot of studies have shown that a single compulsory national health insurance scheme is one of the best ways to get to most of the population. Where voluntary schemes are not like medical schemes here, unfortunately, are not going to, do it for us. And we see, just a second, we see that social health insurance is, is also a way to go, but the continent faces high unemployment rates, right? And we also see that, countries can adopt innovative financing approaches like sin tax, levies on mobile phone tariffs, diaspora bonds. This one for me is also very, very interesting. This is something that I personally like, where the African diaspora can key in to financing their health system back home, and also public-private partnerships. But of course, the challenge we have, especially with the single compulsory NHI scheme, is that it will depend a lot on tax revenue. But when we look at this, we see that African countries have not really been able to get much tax revenue. I mean, we have opportunities to get more tax revenue than what we have, because our tax to GDP ratio are still quite low. But the challenge here is you have, in many cases, because of the higher unemployment rate, you have a shrinking tax base, and you also have a very large informal sector. So we have to be creative in ways of raising resources domestically to reduce our dependence on external financing. So I will stop here, and maybe we can go ahead to discuss this subsequently. Thank you very much, and sorry for overshooting the time a bit.
Not an issue at all, because it's a really important and interesting discussion. But unfortunately, I do have to be a bit cognizant of time. It's my one job as a moderator, and my other one job is to, again, encourage you guys, last chance to send in your questions. I don't know how else you think I'm going to know how smart you are if you don't send in some questions for our panelists to answer. So with regards to that, let's open up some of the questions to be answered. The first question that we're going to ask is going to go to Vuyo, and Julia says, I particularly like the idea of taking a historical look and trying to understand the inequalities we are seeing in contemporary society. In your view, is enough being done to learn and deploy lessons from history? And will COVID-19 bring a significant shift, or is it another adversity that will be normalized? So Vuyo, if you could unmute and answer that for us.
I don't know how to answer this and not sound pessimistic. And I think because of how I think things have unfolded, in the sense that the history that I was mentioning and the things that we know are things that are known and the things that are supposed to be taken into consideration when making policies. And I think maybe there will come a time when there's a shift. For example, institutional wealth tax is part of, redressing the historical issues that have contributed to what we have now. So hence why I always think it's important to go back to history and mention how things, the root causes, and link that to why a certain position is being tabled or why we're advocating for certain things. So I don't think it's something that's going to drastically change or, be taken into consideration now, but I think that it is important to keep linking the root causes of the history of why we have such deep levels of inequality today in contemporary times, and what can be done about that. I think that goes a long way in pushing for, these progressive reforms.
Yeah, that is a great answer to that question. The next question I'd just like to go to quickly, I think is also a great question because it's one of the questions I wanted to ask as well, is to Maureen. And this is, where would you situate the role of government in expanding capability? How did we get to where we are? Just also to contribute my thoughts to that question is, I'm also studying institutions. So my question similar to that is, do we even have the capacity to follow the recommendations that we've talked about in this session today, or would it need to be coupled with other action like dealing with brain drain, bureaucracy, and corruption in our states?
I think it's a great question. What I'd like to do is make 2 or 3 suggestions and then see whether my fellow authors of this presentation want to jump in. Three things I would say is, first of all, there is the capacity to accept that local industrialization matters. I think that capability is there. I think it's being developed. I think there's a lot that's genuine in that commitment. Making it work is something else. I think the 3 really important roles in this field for government, all of which are possible, is decent regulation. Regulation in the medical field is absolutely crucial. If you can't make regulation work, you won't have a medical manufacturing industry that the health system can use safely and that can export. So regulation can be done. A number of African countries have decent regulation. There's no reason why that can't be extended. The willingness to use health funding as an industrial tool. It's very unfamiliar. It's beginning to be less unfamiliar. We're beginning to see much more dialogue between industry and health. There's no reason why, there's nothing incapable about that. It can be done. And trying to do something about industrial financing, which for the whole industrialization drive is absolutely crucial. The availability of affordable, patient, medium-term finance that can fund upgrading and technological transfer. There's the development banking, essentially, in its various forms, is crucial. There's a sense in which we know it's possible and we know it can be done. And the issue is really doing it. And I'd love to know whether Jeff, Andrew, or Julius would like to leap in.
Yeah, I think Chijioke, if you can also leap in there, because I do think it's a really important question. I mean, if I would also phrase it to your presentation as well, which brought in a lot of important information, I would ask, as an audience member, is it as simple as just increasing funding and our focus on the healthcare sector, or would it need to be coupled with other actions? And if so, what actions?
Thank you very much, colleagues. And the short answer is that, I mean, money doesn't do anything on its own. So it's not just about increasing funding, right? And that was why in the presentation, even though I might not have spent as much time on it, I put some caveats on some of the slides to say, for instance, when we are talking about the national health insurance, we have to cut out waste. So for me, the question, when we ask, for instance, let me link this up to the question asked by Salim, in terms of, he said that it's just, the problem is just that we don't have the money to spend. But maybe I will change the focus here to be, first of all, how important is health to us? Because maybe I'm passionate about this because I'm practically, a health economist to an extent. For me, health is one of the most important and critical aspects of nation building. Do we need to spend on health? Absolutely, we need to. Then how do we go about it? And I think that is where innovative financing comes in. And I did mention some options. I mean, when you, as a country, as a region, when you identify an issue, let's say, for instance, the local manufacture of vaccines. Now, COVID-19 has done one good thing, despite all the gloomy stories that have been told, especially with regard to Sub-Saharan Africa. It has convinced us that we are on our own to a large extent. We saw all the vaccine hoarding and everything because every other person is looking out for themselves first and foremost. So what do we do as a continent? I suggested a number of things. So one principle of health financing to an extent in terms of ensuring equity is that you try to reduce the fragmentation of resources that you are going to use, of pooled resources. You pool resources together, it helps you to get more bang for your buck. It helps you to get more value for money. Because when you are a single purchaser of health services, it helps you, it gives you a bit of more leverage. But even also this issue of diaspora bonds, for me, sometimes what really happens on the continent, in the region, is that we sometimes borrow and do things that are not of immediate benefit. You know, when you talk about diaspora bond, and we have to try these things out to try to to bring in the support of Africans who are in the diaspora. I mean, look at the value of remittances that comes back to the continent every year. So my point is that saying that we don't have the money is being fatalistic. We are not going anywhere. We still keep on being sick and we keep on dying. So for me, yes, the problem is not just money, and we have to make sure that we strengthen the institutions in place so that we do not waste the resources. The resources are not embezzled, because this is also a big problem plaguing the continent.
Yeah, thank you so much to that answer. I think that that's a brilliant answer to that question. I think, unfortunately, unless Maureen, you have something left to say because you're still unmuted. Okay, I think, unfortunately, we're going to have to stop there due to our time constraints, because we are at a festival. We've got many more panel discussions for you guys to go to after this. Thank you so much to everybody who came and attended to this session. I'm so happy with the turnout and the amount of engagement. And I'd also just like to now give each of our panelists an opportunity to put in a final word, something they want to do to wrap up the conversation, or just to tell you about any future projects they have coming up, or where you can find them on the interwebs. So Vuyo, if you'd like to start us off with that.
I don't have any new thoughts to add. I just want to say I'm really grateful to have been part of the conversation. I think it was really, really enriching inputs from the other panelists, and I look forward to see if I can attend other sessions throughout the festival. So just thanks so much for having me on today.
Excellent. Maureen?
Same thing, thanks very much. And also to say, watch this space, because what we've been presenting is interim work for a report for the IEJ, which will be coming out in due course, sooner rather than later. And the IEJ will no doubt circulate the link when it's available. Thanks very much for listening, and thank you for having me in a really fascinating panel.
Oh, thank you. And then lastly, Chijioke.
Yeah, just to say thank you also from my side. I'm really grateful. Thank you for inviting me. And I mean, health financing and the health systems strengthening generally are my passion. And but I mean, I just want us to, the word I want to leave with the group is just that this can be done. We can't give up. As a continent, as a region, and COVID-19, as bad as it has been, it has shown us that our destiny is in our hands, and let's try to be innovative in financing our own healthcare. Thank you.
Thank you very much for that. Last comment from me in terms of the REFA Festival. Our next set of sessions will be starting at 5:30. So you have a 15-minute comfort break, and they're going to be running until 7 p.m. Please join a session. You can find the links in the chat. I've dropped everything there for the individuals and for just the website in general. If you want to follow me around, I'll be attending REFA Stream 2, Session 2, debating the role of Universal Basic Income grant, which also Vuyo talked about as a possible policy response answer the inequalities here. And please further engage with us on social media so that we can grow and solidify our network of rethinkers. You can find my chapter at Wits REFA on all platforms, and you can find the festival social media at REFA Fest on all platforms. And if you do post anything, please use the hashtag REFA Fest 2021 so that I can find you and engage with you and retweet you. So thank you everybody so much for being here today, and we've ended just on time. I feel so accomplished. Thank you so much for joining us, and I'll see you at the rest of the sessions in the festival.
Thanks
just a general bye.
Thanks very much.
Thank
Bye.
you. Bye.
Bye, everyone.